Good afternoon, everyone. Thank you for joining us for the Healthy Transitions Colorado June 2014 webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm happy to be here today with you as we discuss using paramedicine to improve care transitions and reduce readmissions. So Civic is the managing partner for Healthy Transitions Colorado in collaboration with our partners Telegen, formerly known as CFMC, the Colorado Hospital Association, the Colorado Healthcare Association, and Colorado Rural Health Center. HTC is a collaborative effort, and we're focused on aligning and accelerating the existing efforts to improve transitions of care for Colorado. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for the campaign follow the triple aim. Over 2 years, we hope to eliminate a total of 8,700 readmissions, eliminate over 34,000 days in the hospital, and save $80 million for Colorado. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC and what we do, visit our website at www.healthytransitionscolorado.org, or you can email us at hello@healthytransitionscolorado.org. Just a couple things before we get started. The phone lines have all been muted and will remain so throughout the webinar. We're going to be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenters will be answered during the Q&A session that we have at the end of the presentation. This webinar is being recorded and it will be posted to the HTC site so that you can access this information again at any time without cost. So I'm now going to turn the program over to Ann Robinson-Montera, Public Health Nurse for Eagle County, and Chris Montera, the Chief at Western Eagle County Ambulance District. They're going to be talking about the pilot they're launching to use community paramedics to bring care to patients across Eagle County. Chris and Ann?
Hello, everybody. Thanks for having us. My current role is I'm a public health nurse consultant. I'm the former nurse manager from Eagle County Public Health up here in Eagle, Colorado, on the western slope, and I have just been working on community paramedic programs nationally, across the local, regional, state, and nationally. I've helped develop the community paramedic curriculum, which we'll talk about as we get going into the presentation, but thank you for having us. We really are excited to be here today.
And I'm Chris Montera. I'm the Assistant CEO of Eagle County Paramedic Services. We've gone, I don't know maybe where they got my title, but we've gone through a little transition up here as well. We merged both of the services here in Eagle County about a year and a half ago, and we're now running as one large countywide system with 5 stations, over 85 employees, doing everything from 911 response to critical care, ground transport, to community paramedic services, as well as injury prevention and public health prevention in our community. That's us, and we also like to tell everybody that we love presenting. We love presenting to large groups all over the world. They actually had us in Hawaii recently, which wasn't terrible.
No, that wasn't bad at all. But my favorite place that we've ever presented was at the largest, we were privileged to go to the largest water park in North Dakota, and it happened to be during a huge blizzard. So we were stuck in this hotel for 4 days and got to do our presentation a couple times over.
Yeah, because they didn't have many people coming.
No.
And then also we like to remind people that always wear your helmet because you'll definitely get pulled over. So some of the presentation goals today, we'd like to tell people about the history of community paramedicine and that this isn't a brand new concept. This is something that's been going on for a long time, and not just here in Colorado, but all over the world. Tell you a little bit about Eagle County Paramedic Services, what the role of public health is, how to mobilize a program, the education that goes along with it, and then at the very end, we're going to show you some of our evaluation that we've gone through and talk about how we have ensured not only patient safety, collaboration, partnerships, and that we have reduced costs for our patients in our community and increased health outcomes. So the history of community paramedic actually started in a guide called the Rural and Frontier EMS Agenda for the Future. And in that guide, if you will, it was a white paper that was developed in 2004. And in that, it was the first time in history where the words community and paramedic were utilized to say that perhaps we should use paramedics in rural environments where they're really needed. You really need a paramedic in a rural environment to take care of patients for long distances and to have a highly skilled, highly trained professional. You probably don't need a paramedic downtown Denver, but that's how the model's been set up, at least nationally here, where we have the ability to pay for paramedics in the urban systems, but we really don't have the ability to pay for paramedics in the rural systems. So this paper really outlined the idea of how we can make rural and remote paramedics available to communities where they really need it and integrate them into the healthcare system when they're not on 911 calls. So because of that, the International Roundtable on Community Paramedicine was born. And this year is our 10th anniversary meeting. And community paramedicine is truly an international collaboration between the UK, Switzerland, Dubai, Qatar, Australia, New Zealand, the United States, and Canada. And we all meet once a year as a large collaboration and talk about things that are going on in our countries, as well as how we can further the movement of community paramedicine. This year, the IRCP event will be held around the Burning Man event in up north of Reno, and the IRCP is absolutely free to attend. IRCP will be the first week in September 2nd through the 5th. And if you'd like to attend that, go to ircp.info, and you can find all the information there. Burning Man, if you may or may not know, is a large art gathering in the desert, and Ann and I have had the privilege of working there for the past 2 years in the hospital and the emergency response system. And it's really one of the truly best healthcare experiences I've had in the 25 years I've been in medicine. The Paramedic Foundation is also a big supporter of what we're trying to do, and they're a large, they're a think tank foundation here in the United States that's trying to change the way we think about paramedics around the world. So Eagle County Paramedic Services is, as I described earlier, is a system that was formed from 2 health service districts. We're in the state of Colorado. There are several mechanisms to have an ambulance service that's provided by government. A health service district is one of them. Years ago, our county was divided in 2, and in 1982 and 1988, respectively, the tax authorities were born. We report to a board of elected officials, and we just finished our merger January 1st of this year. So this was how that line used to be. If you aren't familiar with Eagle County, we are the county that also encompasses Vail and Beaver Creek, as well as the communities of Gypsum, Eagle, Edwards, Walcott, Bond, and McCoy. Our county has a unique population. We have about 50,000 full-time residents, but in the wintertime we can have upwards of 100 to 110,000 people in our community coming in. Now, a lot of people around the state would say, well, we don't really see why the communities of Vail and Beaver Creek would need something to help provide healthy transition, but we're going to show you what our uninsured numbers are here in a minute. We have one of the highest uninsured rates in the state. So Eagle County Paramedic Services, we do about 4,500 calls for service per year. We transport to 2 primary hospitals, Vail and Valley View Hospital in Glenwood. We do critical care ground transport, prevention, and community paramedic services. So some important factors when we started doing and formulating our program in 2009 was that we needed strong medical director buy-in, we needed community buy-in, agency buy-in, and then we also had to look at our policies and procedures and start thinking about ourselves as a healthcare organization that occasionally does 911 calls. And we stick to that mantra today, that we are truly looking to be a healthcare organization that occasionally does emergency work. We also had to have staff willingness, and we had to change the way we thought about paramedics, that we're truly trained and educated healthcare professionals. So some of the early work we did before 2009, and we currently do today, is we do a community CPR program, fire department training. We cover 5 fire departments or fire districts as well, and we do all of their medical education for those programs. We have a clinical education department that handles our internal clinical education as well. We do car seat checks, a camp for 9 to 11-year-olds called Camp 911. We do the typical senior blood pressure checks and other community events. So those are kind of the foundations when we started looking at how we could start providing different types of services in our community. I also worked in public health back in the early 2000s, and for me it was important to see how could we take our EMS service and turn it into a community benefit that was helping all of the providers in our community fill gaps and find gaps in care. So that's when we started partnering with our local public health department.
And that's where I came in. So in 2009, Chris came knocking on the door and to our public health department and said I wanted to start this program called Community Paramedicine, and at first I really didn't even have an understanding of the difference between an EMT and a paramedic, and being a nurse in the healthcare system in different roles in hospitals and clinics and public health, we knew from that point that there was a disconnect for the rest of the healthcare system understanding EMS and really what they bring to the table in the first place. So that started us on our journey, and we really do give this presentation a lot, but it's mainly to EMS professionals. So my next piece probably is not going to be too foreign for this audience, but I still like to go through it. When we started this in 2009, it was before all of the healthcare reform talks were really being started, and we knew that we had problems in our community. About 80% of our ER visits were for primary care, and we knew that we needed to look at what ways to decrease readmission rates. And so these were our goals from the very beginning in 2009. So this map that you're seeing isn't what we would call our Verizon Wireless 4G coverage map, but it's more our HPSA, which is our healthcare provider shortage area. And what that is it's a federal designation that you receive depending on the number of healthcare providers you have in your community to your population. And if you don't have enough providers, then you can receive this designation and you can receive additional funding from Medicare and Medicaid. So in Colorado, this is what our map looks like. And Eagle County is a big white spot in the middle. You'll see Eagle, Pitkin County, Gunnison, Chaffee County, and this is our rural resort area. Why do these areas or counties not have this designation? And it has to do with, we have a lot of physicians that like to come and visit up in our area and work for 2 weeks while they're skiing in the winter, and so it skews some of our numbers. Since then, we have received the designation and just opened this last fall an SQHC, so we've come a long way since we started this program. We also know, and I'd like to talk about what's going on with Colorado nurses, we have an aging nursing population. Over 20,000 nurses are going to be retiring in the next couple of years. So we knew that there was a need and there would be some gaps to fill in the healthcare system. We also know that our public health workforce is diminishing by 1/3. And knowing that this was a very public health driven program, we knew that community paramedics and paramedics in general could come in and fill and help public health nurses out and public health departments in meeting these requirements that they still have from the state health department. So like Chris said, these are our uninsured rates. So looking at us in Eagle County, sitting at 29%, we knew that we had a huge access to care issue. Now when you saw the county slide that Chris had earlier, when we first started this program, we started only on the western side of the county, and at that time we had a 59% uninsured rate. So again, we knew that we could, this program would, a goal of it would be increasing access, which sounds like this is just right in line with this Healthy Transitions Colorado program. Readmissions rates. What you're looking at are readmission rates for Medicare patients, and they're being readmitted in less than 30 days, and what it's costing the healthcare system. So then we knew what it looked like in 2004 and 2009, and now with 2014, with where we're not getting reimbursed for those readmissions that occur in less than 30 days. What is this going to be, and what can we do to make an impact on this? So I'm going to take you through a quick exercise. I want you to think about 1,000 people in your community. It could be a neighborhood or it can be an entire town. And out of 1,000 people in one single day, about 250 of them have some sort of a symptom or some medical condition that will occur. One could have a heart attack, you could break your leg skiing, or you could just have a headache. Out of those 250, 75 of them don't need to follow up with any medical care, while 25 of them will need to get access for primary care. 3 of them will need to see a specialist, and out of all those 1,001 will be needing to be hospitalized. So how was this really impacting on our system in Eagle County? So I kind of turned these numbers and I Eagle Countyized the numbers is what I call it. So I took our 50,000 population and put it through this equation. So out of the 50,000, a little over 12,000, something will happen to them during the day. A little under 4,000 won't need to follow up with any care, but about 1,200 will need to seek a primary care. So I want you to think back. In our community, we have 4 primary care provider practices, and only one of them accepts Medicare and Medicaid. So and the uninsured. So think if we have a 29% uninsured rate in our community and only one practice is seeing those people, think of how many people they would have to see in one day. And then 150 people of them will need to seek a specialist. If you're in a rural community, you don't always have access to cardiologists, neurologists. But if you're in Vail, of course you have access to all the orthopods. But still, again, there's an access to care issue. And then 50 of them will need to be hospitalized. The one hospital in our community is Vail Valley Medical Center, and they're a 58-bed hospital. So think about what can we do to help impact this demand on our healthcare system in our community. So I always like to take the opportunity to educate people about public health, that we are doing a lot of disease prevention and health promotion, and really ensuring that people have a healthy lifestyle, and that we treat the whole population's health and not always just concentrating on individuals. If you think about population healthcare, what does that look like? In our public health department, we do less direct care and more prevention, where if you're in a medical provider's office, they have less time to do the prevention work and really concentrate their time on the direct treatment for you during your visit. So when we started this program in 2009, we knew that we wanted the program to be equally prevention and direct care oriented, and it's been that way ever since the beginning, and we continue to have that be our model. These are the core public health functions that we do with our assessment, policy development, and assurance. And then this goes to show why public health was involved in the first place. We helped with educating the community paramedics and ensuring a competent workforce. We were key in linking EMS, the local EMS agency, to the other healthcare entities in the community that they weren't used to working with, and really helped with developing those policies and evaluating the program from the very beginning. So this is a little more an example that I like to tell people about population health and what that really means. So in our public health department, we do something called a Cavity-Free at 3 program, where we do fluoride varnishing on children's teeth and hoping to prevent cavities by age 3. So we could go to school to school and do all these varnishings on individual children, or we could work at the policy level all the way at the top and get fluoride in our water system, where we would impact a larger population. So that's kind of the difference between direct individual care versus population health. The other thing that we do, and in the state of Colorado, all public health agencies are required to do a health assessment. We based the priorities of our program on this health assessment that was done in the public health department. And what a health assessment does is they bring together all the healthcare stakeholders in the community, and they help prioritize what the health goals are and aligning efforts, so we're not duplicating and working in silos. So our Healthy Eagle County 2010 goals are here enlisted with what you see. And in the first 3 years of our program, our goal was to be able to go with our efforts on the first 3 goals. We have just started our 4th year of our program, and with that we have expanded into our mental health arena, and we'll talk about what that looks like in a little bit later. So then we came up knowing what our health assessment said, understanding our community's needs. These are the 4 priority areas that we came up with from the very beginning, knowing we had a very young population, knowing that we needed to help people with access to care, and really making sure to keep aligning with our public health programs and events.
So what is community paramedic? And I think we'll walk you through some of the history of our program as well as what it looks like in Nova Scotia. So in 2008, the dawn of the idea really happened for me. I took on my role here in Eagle County in 2007. And like I said earlier, I was trying to figure out a way for us as the paramedic system to work with our local public health department to, we weren't sure. We were like, well, maybe we should do an in-home fall prevention thing, or maybe we should do this. And we just couldn't ever get it to take off. So in 2008, I saw a presentation on this very subject on community paramedicine at a large national conference. And the idea kind of stuck with me, and it kind of resonated with how we could do it. But it still took some time for us to really solidify how we could make this program work in our community when really nobody else had done it before. So in February of 2009, it took a little bit of insight, if you will, into some other communities in Colorado, and looking at, we were in Saguache County, and I was having dinner with one of the or that day I met with the EMS manager, and I said, what's your biggest need? And he said, oh, I need paid paramedics here. And I said, well, you only do 158 calls a year. You really can't justify that. But then that evening I went and sat down and I had dinner with one of the county commissioners, and I said, what's your biggest need in this community? And she said, well, my biggest need is we need to hire public health nurses, but nobody really wants to move here because it's Saguache County, and we have more cows than people. And so that night it was like chocolate and peanut butter came together. I'm like, well, they have money to hire people, and this guy has a need to have have paramedics. So how could we then use those paramedics during their downtime to and pay them to live there? So in March 2009, I called Gary Wingrove, who had done that presentation back in October, and said, hey, where's the handbook? We're ready to start this community paramedicine program. And Gary said, you know, there's really no handbook. Nobody's ever really wanted to do this before. He goes, there's a few things going on, but nothing that we really can point to here in the United States that would work. But he said, if you want to go somewhere, go to Nova Scotia. They've had a program up and running since 2004 on 2 small islands. So we went. We took some people from Colorado Rural Health, and we went to Nova Scotia in May of 2009. There's a picture of the flag to prove we went. So we went and we looked at their system, and we went and they were using paramedics in a unique way on these 2 islands in Nova Scotia that it took 45 minutes by ferry to get back to the mainland, and they really had a need to have an ambulance on the islands because but they weren't very busy. They did 1 call every 3 days. So what they did is they took these paramedics and they trained them and educated them on how to go out and check on patients and do other types of work. And for us, it was very important to see and live and breathe what was going on. In fact, you'll see the 2 good-looking people there. You'll notice Carrie Frank is here, as well as Ron Seedorf. Many of you may know him. So we all went out there to see what was going on. So on the plane ride home, we literally wrote the program, and we said there's a few tenets of our program that must exist all the time, and they're tenets that we really believe in today when we talk to people all over the world about what we're doing. One of them is we don't want to compete for services. We want to fill gaps, and we want to always partner with other healthcare providers in our community, and we've done that. Everything that we do, we want to make sure that that patient has a medical home, and everything that we do is physician ordering led, and we've done that. And then finally, we want to figure out how we can collaborate with insurance companies, Medicare and Medicaid. That one's a little bit harder for us, but we're working on it. So really, what are some of the expanded services that we're doing in community paramedicine? Well, we're doing primary care, emergency care, public health, disease management, prevention, wellness, mental health, and oral health. And for us, those key collaborators really helped us to come together and figure out where we needed to fit our model in our rural community. So I always like to take a minute because sometimes we'll have some nurses or physicians on the call that say, well, you're trying to expand your scope, and really we're not. We're trying to expand our role in the community, and we're doing everything that a paramedic is licensed and able to do in the state of Colorado, but we've just changed some of the terms on what they do. So we keep everything within the current scope of practice for paramedic, for paramedicine, but we have areas of focus. But then for me, it was also important to understand that we have more education for the paramedics, and we'll go into what that looks like here in a minute. But all along, it's really about filling the gaps. So what we did, and this is a list that's meant to overwhelm people, because what we did is we took what we do as paramedics today, and we may call it something else in paramedicine, but what we really quickly realized is we needed to have a way to healthcareize and change what we say we do into healthcare terms that most people understand, and we did that. So for us, it was also important to engage those partners. So after we got home in June of 2009, we went and we started meeting with everybody in our community, from community leaders, nurses, physicians, advanced nurse practitioners, home care agencies, our county commissioners, everybody that could have a stake in the game. We wanted to meet with them and find out how we would collaborate and not step on toes with the program, because we felt it was important. So in late July of 2009, we rolled out our program officially to our community and had a large community event, and that was kind of a turning point for us when we knew that we could go forward and do good work. So from then up until today, we had several processes that we went through where we did the education piece. We had to become a home care agency, and I'll show you that here in a minute, how we did that. But for us, how do you identify a patient? And that was important for us to understand, and how the process would work, and how we always kept that patient and physician or nurse practitioner or medical provider relationship intact when we're just intervening. So first it was identifying the patient. How we do that is through the EMS crews, the emergency department, the hospital, primary care, public health, home health, hospice. However that patient's identified, they send us a referral. So an order's created. We then will schedule the patient. The community paramedic will call the patient to make sure, A, they know that we're coming, and B, what the expectation of our service is. We go visit the patient. The typical initial patient visit is between 1 and 2 hours. We do a lot of typical home care assessments when we do that. Not only the initial patient assessment, but we do an in-home fall risk assessment. We do something called the PEAT scale, the physical environmental assessment tool, where we look at all of the things that relate to that patient's health, as far as do they have heat, water, food in the refrigerator, things like that. And then we follow up with the primary care provider through charting, and we will send a chart back to the primary care provider on what we found in the home, how we helped the patient, and what services we provided in the home. So for us, we had some legal issues we had to overcome. We had to become a home care agency, and because of that, we became a health service district. And then a lot of people always ask us, what about the liability in this? And for us, our insurer has said that we're doing everything that a paramedic does. We're just doing it on a longer-term basis, if you will, over an hour or two. And our insurer said there is no additional liability from medical issues that we're doing. So for us, we wanted to make sure all along that we were providing the right steps to go through. So Anne's now going to talk about the education model.
And this education piece has been very key and important to the success of our program. It really is the foundation that our paramedics, it's building on the foundation that the paramedics have. We know that we have EMTs that are already delivering care in the local communities, that they know how to access resources, they know where to make referrals. They also are familiar with how to fill those gaps. So with that, we developed the International Standardized Community Paramedic Curriculum. And at the end of this piece, I'll tell you why we think it is the standardized curriculum. We've just completed a research project on that that's been published. So the owners of the curriculum, which is the North Central EMS Institute, created a committee, which was the Community Healthcare Emergency Collaborative, or we'll call them the CHEC group. And this is the stakeholders that came together in 2007 and made the decision that a curriculum needed to be made. And so when they first started talking about this, they saw the long-term vision and knew that it would start at just a level that might not even be a paramedic, that it could eventually work towards an associate's degree for paramedics or EMTs, and then working in the future into a bachelor's degree, and then maybe even internationally we're seeing this to become a master's degree. So upon completion of the first version of the curriculum, they really thought that upon completing it, that the paramedic or EMT would have a certificate from the college, or it would be a path of an associate's degree. So looking at what, from there, the course had only been taught one time, and then they updated it to its second version. And this is just to show you what it kind of looks like at the time. It was, when printed out the curriculum, it was about a 5-inch ring binder of a lot of teaching materials, and it was hard to organize and really get it set up to be a successful course. We taught the course for the second time ever here in Colorado in 2010 in its second version. And from there, we knew that our small class of 12, that this would expand, but it needed to be more standardized to its third version. I was tasked to pull together a group of people, and really, again, we want to standardize it, create it to be more an educational format versus a training, and really it is to ensure quality programs would be developed in the future. So this is a group of people that I've put together from all over the nation with rural and urban representation to help me update the curriculum. We went through a whole process in 2011 to do this, engaging those stakeholders to help me out. I pulled everyone together in a strategic planning meeting, and then we started to organize what this would look like. And I'm going to describe that to you here in just a minute. But we did the didactic modules 1 through 6, and then we completed module 7, which was our lab and clinical modules. The whole process really, it took us a little under a year to get this all done. And then upon completion of this, we had another group that was a review team to validate the work that we had done. They watched through our whole process from the very beginning. They verified our structure was going to be successful. Then they went over and looked at all of our lesson plans, approved all of our lab and clinical pieces, and then finally I had them read the curriculum from cover to cover and do the final approval. And this is kind of what that curriculum looks like. And really in the end, we really feel like we made an educational resource manual for any college or university to pick this up and to be able to take it and ensure these high quality programs. So upon the completion of the third course curriculum, we really felt it was like a 300-level college course, and so we feel that it would be a great stepping stone towards a bachelor's degree. Now, does that mean that a paramedic or EMT has to have an associate's degree to take this course? No, but I'll show you here in a minute that they do need to have some sort of college education in order to be successful with the class. I always like to thank all of our sponsors and stakeholders, and the Colorado Rural Health Center has been by our side from the very beginning and did help us with dollars to be able to pay for this current version of the curriculum. So thank you, everyone. So if you don't know your Rural Health Center, you need to get to know them. So here are the modules and how it's organized. I like to go through this so people can understand that we're really giving the paramedics and EMTs the skills and expertise to be able to go out into the community to provide this expanded role. So we have the 7 modules. The first 6 are the didactic, like I said, and the 7th is the lab clinical. If you would overlap them, they would take up as equal amount of time. So 1 through 6 would take, say, a semester in length, and the 7th one would take another semester to get their lab and clinical time done. So I'm going to just quickly go through some of these modules. The first module is the role in the healthcare system, so the paramedics would understand what is a community paramedic and how they're working differently with different providers. The second one is getting them to know about the social determinants of health and what I would say the biopsychosocial spiritual well-being of all of our patients and treating the whole person. The third one is them understanding more about public health and primary care, again, a new realm for EMS, and so this was important for them to learn about those prevention efforts that we talked about. We added a whole module on cultural competency to be able to meet and treat their patients at the level that they're at and with their understanding. Module 5 is our largest didactic module, and this is when they come in and do a health assessment with the local public health and really understand all those webs of resources that they have in the community. The 6th module has to do with their personal safety and wellness and taking care of themselves, and then also healthy education and teaching of our patients as well. The 7th one, which is the lab clinical, this just gives you an overview, but it's really, this is to be customized in the community per what, based on what their program is all about. And so if they're doing an asthma program, then they would do that clinical time in that area. So we did do a pilot, and I'm going to go through this part pretty quickly, but we did a pilot in 2012 with the new curriculum through Colorado Mountain College and Hennepin Technical College out of Minnesota. We had multiple agencies participating, and we had requirements for them to be able to participate with all of the buy-in and support from their medical director. And they had to have the structure in order to do all of the didactic lab and clinical time. And so the program length ended up to be a program we're seeing to be 12 and 15 weeks in length. It's now 12 to 14 credits for colleges that are giving credits for it, and that includes the clinical and didactic piece. This is the overview of what the structure looks like and the time that it takes. It's about 100 hours in didactic time and 100 to 200 hours in clinical time. So how do you get a hold of this, the curriculum? It's available free to any colleges, universities, or state regulators. We do ask people to sign a copyright to make sure that they don't distribute it. And so distribution-wise, we've now distributed over 200 times, and it's been requested more than that, but again, we are only giving it to the colleges and universities that are requesting it, that are accredited. So this is how it's been distributed by state. I think it's, there's a course going on at Pikes Peak Community College down in the Springs. So it has been distributed throughout Colorado and being taught. And again, we said this was international, so this shows kind of where it is across the world. Like I said at the beginning, we did research. We needed to know, since we've distributed so many times, how is the curriculum being used? Is it standardized? Is everyone doing it the same? And kind of it would gauge us on our future goals and development. So we just, through the International Paramedic Practice, just had a research paper about the survey that we did and all of the results. Really, it's great to know that we had a huge response of the colleges. At the time, only had 145 colleges that had the curriculum. And really that we see that over 35 are currently teaching or ready to teach the curriculum across the nation, and 12 more are planning courses. And we feel that in the future we could have, in the next 5 years, over 167 active colleges teaching the standardized curriculum. So we're going to go quickly into what our measurable results have been in evaluation.
An important point on the curriculum, UCLA out of California is just, the state of California has adopted this as their standard curriculum in California, and UCLA is working on a pilot project there and actually helping UCLA with their rollout in California. So some of our measurable outcomes, measurable outcome number one, we want to ensure all patients had a medical home. Excuse me. Medical home is a very loose term we're using. Really that should say we wanted to ensure all patients had a primary care provider after our time with them, or because sometimes we get engaged from the EMS side and we don't know if that patient has a medical home or a primary care provider. So to date, we've done that 100% of the time, and we ensure that 100% of our patients have that, and we've been doing it now over a little over 3.5 years of providing service. Number of vaccinations given and public health visits. I always wanted to be able to count something because I think that's important and it's easy to do. In our first year, the community paramedics gave over 350 vaccines, but during H1N1, Ann was the the director of the public health department here, and she utilized our paramedics in the system to give over 90% of the 17,000 vaccines that were given in our community that year. So it was a great partnership it was kind of a proof of concept that we could really do it back in 2010, wasn't it? That one, I don't remember.
Yeah,
it was back then, yeah.
Yep.
Next one is injury prevention versus potential costs associated with no prevention. A little harder because today we can't prove that if we move something in a house that it prevented a hip fracture in the future. But there is some research going on right now in Hawaii, and doggone it, I wish they'd send me there again to talk to them. But the researchers are really being able to apply dollars and future dollars to how we do things in the home today and how we prevent injuries in a home. So number 4 was reduce hospital readmissions by 50%. For this, we partnered with Vail Valley Medical Center between March of 2013 and March of 2014 this year. So we did something called Project Red, and that's re-engineering discharge. And we were a part of the process where the community paramedics called all of the patients over 1 year post-hospital discharge to see how they were doing and do all of the follow-up calls for the program. During that year, we contacted over 1,100 patients in the program. And to begin with, our readmission rate was 4.26%. A year later, it was right around 1%. So we reduced the readmission rate in our community by 75%. And that's quite stark because it was such a low number to begin with. I didn't think we would see much movement. But to see that kind of movement after 1 year was pretty remarkable. So the final one is kind of the meat and potatoes of this program, and we'll probably spend the majority of the last few slides here talking about it. We wanted to calculate the cost of the community paramedic program versus the cost of ongoing care / hospital care. So what we did right from the beginning is we found these measurable results, 1. Number 2 is we collected data from patient 1. And we had an outside evaluator. She's a master's in public health, helped us develop the tool. And then Anne was the outside consultant that helped us look at all of our patients through the system, as well as our medical director. And then finally, we hired Eide Bailey. They're a healthcare, or they're an accounting firm that also has healthcare economists as part of their structure. So we hired a healthcare economist to do all of our number crunching on all of the healthcare savings that you'll see in the next few slides. So our initial findings, our initial cohort of patients was July 2012 through December 2013, 55 patients, 216 visits. Oh no, sorry, this is cohort. This is cohort 2. Sorry. I have the wrong slide here. But anyway, this is cohort 2. So this is all of the next data you'll see. Cohort 1 was actually very interesting, and I'm sorry I didn't include those in this one. I'll include it next time. But cohort 1 was a little bit, it was about half as many patients and about half as many visits. But our numbers and our cost savings are exactly the same, which was important for me. So we'll show that here in a minute. Is it next?
It's in here.
Okay, cool. So our demographic data, 36% of our patients were under the age of 10 and 47 were over the age of 65. 40% were Spanish speaking. Our provider referrals came from primarily physicians, physician assistants, and nurse practitioners. Our insurance types in the community, 18% were uninsured, 80% were on some sort of public type insurance, Medicare or Medicaid, and 2% were on private insurance or commercial insurance. Services prevented. So this slide shows you what type of services we prevented, and I'll show you the actual hard numbers here in a minute. But 70% of our patients we prevented from needing some type of nursing facility care or skilled nursing care. We prevented 11% ambulance transports, 5% ER visits, 10% physician office visits, and 4% hospital admissions or readmissions. And here's those numbers. So for us, and when we start talking about healthcare savings, the ambulance transports alone and the ambulance transports we saved in our system, because of the type of patients that we were taking care of and the type of payers they would have been, we saved our organization alone over $84,000 during this time period in just reducing the ambulance transports or the ambulance transport need from patients that couldn't do that. So what I'll show you here is our average savings per patient in Cohort 1. Cohort 1 was, again, fewer patients, but we had $1,279 of healthcare savings. And when I say healthcare savings, here was the definition we used. Somebody in the healthcare system would have had to write a check to have that care provided, or would have had to written it off. So it's really the same side. So somebody had to pay something in the healthcare system. So average savings per visit was $1,200. Average savings per patient was right around $3,400 for our first cohort of patients. The next cohort, which is the one I just reported on, was right around $1,300 per patient visit, and right around $5,200 per patient that we saved in 2013. So when we do all the math, and you want to do the home math, in 3 years, our average healthcare savings was right around $412,000 in our community alone. So we believe, and I believe highly in open source, and I think that's what we promote here in our community, and especially in my organization. And so we wanted to be open source. So when I told you early on that there was no handbook, well, we wrote a handbook, and we've given it out over 5 times a day since October of 2011. That's right around 3,000 or 4,000 times our handbook's been downloaded and read and reviewed on every continent except Antarctica, all around the globe. And for us, it was a defining moment, because we wanted people to understand the good, the bad, and the ugly of what we went through to create our program and why it's so important. So you can find the program manual and the curriculum at communityparamedic.org. You just go there, and we'll show you that website here in a minute. But Anne's been working on some policy work at the national level.
So we felt it to be very important to bring not only stakeholders together at the local level, at the state level, but then 3 years ago we started working with American Nurses Association and met with them in DC to educate them about what is this idea of community paramedicine. Not only was there disconnected out what is EMS, but then we also wanted to make sure to keep them on board with us. So we developed alongside them our guiding principles for state programs to work alongside with nurses and community paramedics to make these successful. We've also been working in the state of Colorado as well, and we are hoping to start, we're doing community meetings and to do going for legislation to create the community paramedic as an actual provider of service and then a designation agency type. So we hope to introduce some bill into legislation in January with that.
So here's our recap, and I think we hit most of those. So we have reserved this time for questions, but I'm going to turn it right to our contact information so we can leave that up while we take questions.
Absolutely, and thank you guys. This was great. It was really nice to hear how you guys are really getting into homes and filling in some of those critical pieces that we've been hearing about lately. You know, really drawing attention to the social determinants of health and making sure that issues of safety within the home get addressed at the beginning rather than after we've had several successive falls. And I'm going to give folks a few minutes to enter some questions into the chat box, and I'm going to go ahead and take presenters priority and ask a couple questions myself, if that's okay.
Sure.
And you were talking about some of the policy work that you guys have been pushing. What has been your biggest policy challenge that you've encountered during this process?
I think it has to do with the lack of understanding about EMS and what the provider of a paramedic can provide in the first place. And then also just their lack of understanding about how that we're not taking jobs away, we're not stepping on toes. But then it's also, I think we've had some pushback from within the EMS community themselves and not wanting to be regulated. And for us, it's been important that that it is regulated and to ensure safety and quality of services and competencies are in place. So I think those would be our top pushbacks that we've seen.
Yeah, I'd agree with that. I think the biggest one is people just not understanding what a paramedic is to begin with, and then how do we partner and that we're not a threat. I applaud the nurses we've been working with because, as you can imagine, a lot of the people say, well, nursing will hate this. And actually, after we sit down with our colleagues in nursing, they understand that really we're just trying to help them and be a part of the healthcare system. And that to me has been probably the biggest aha moment.
Yep.
Great. That actually leads into my next question, which is, can you talk a little bit more about how this work is different than the work that would be done by, say, a home health provider?
So the way I kind of describe, not only within home care, but say in public health, home care nurses have specialties in providing highly skilled services in home care. Now, there is overlapping roles where community paramedics can do some similar services, but community paramedics can come in and help supplement some of that, but really free the home care nurses to be able to do the highly skilled areas of expertise. It'd be the same in public health, where community paramedics can come in and do the vaccinations, where then it would free up the public health nurses to do more of that high-level policy work.
Well, and I think the other piece to really understand is our community paramedics don't write care plans, and nurses and physicians are the care plan holders for all of our patients. So we really pride ourselves on partnering with. So everything we've done in our community, we have memorandums of understanding. So we have MOUs with home care agencies, hospice agencies, the hospital systems, the clinical providers, our mental. We just recently signed a MOU with Mindspring Health, which used to be known as Colorado West. So so for us, it's important that people understand what our role is in that, but we're also filling gaps where home care may not be able to take care of a patient, or a patient doesn't qualify for home care or something like that, where we could come in on a 1, 2, 3, 4-off visit and take care of a patient's needs post-discharge, where maybe home care would need a longer-term stint, or the patient just didn't qualify to begin with. So we're really filling gaps in that area.
Great, thank you. We've got a question from Marie, sorry if I'm mispronouncing your name. How does the charting work to keep the primary care providers informed about community paramedic services provided to their patients?
That is a great question. And we can get this presentation in 8 hours, or then we can stretch it into this hour. So that's one big problem that we had is EMS charts in ePCR systems, and they chart per incident. And where healthcare has a medical record in EMRs, and they chart, one patient has a whole medical record, and their visits keep accumulating within that medical record. So that is a big disconnect on how we've had to set up our documentation. So we do a lot of narrative in our charting, and then we have it's an overview sheet that then we send to the physician afterwards. But we actually have paper medical records for all of our patients.
Yeah, it's not the most robust, but it works. And the other great thing about our program is if a paramedic's in a home and they find something that the patient needs immediately, or I won't say emergently, I'll say urgently, the paramedic has access to that patient's primary care provider. And for us, that's been a huge win, because when the community paramedic calls the physician or the physician's office, we're routed to the back office, and the physicians know we're not calling them for routine matters. Routine follow-up is handled via fax and sent to the office directly. But if it's an urgent issue with the patient, the community paramedic has all the rights and authority to contact the patient's physician to get things handled immediately. So there's that immediate follow-up, as well as the follow-up within 24 hours of the patient care report getting back to the physician. And generally those happen within 4 to 6 hours of our visit, as a rule.
Great, thank you. And I think we've got a question in the room here. Carrie Frank.
Hi guys, hi Chris and Ann. Thank you again for this presentation, and thanks for pointing out that Ron was handsome in that picture. I wouldn't say I was one of the good-looking people. But,
you were beautiful. You were beautiful.
Thank you. I was wondering, just for folks who are, working specifically on readmissions, what kinds of cases have you guys seen most of for what kind of things are you doing post-discharge that you think have been making the biggest impact to reduce readmissions with Vail Valley?
I don't remember.
The number one readmission is for pain control because of our large orthopedic population. So with us following up 24 to 48 hours afterwards, we're really ensuring that they not only understood their discharge instructions, that they actually got their medication prescriptions filled, they were taking them, knew how to take them, they were staying on top of that, staying on top of constipation, and taking care of their wound if there was one, and then ensuring that they were following up with their primary care provider or their surgeon as scheduled. And so when calling a lot of these patients and interacting with them, it's really crazy to see how many people don't understand their discharge instructions or any of those 5 main points that we could really make the biggest impact with.
Yes, then we did teach back and made sure that they understood, hey, are you understanding this? Yes, and tell me back what you're going to do. So it was very important that when we were talking to the patients that they had an idea. Sorry, that question threw me a little bit because I was thinking constipation, which was number 2 on our readmission. And so actually we have, there's now a new medication out that actually acts on the opioid receptors in the large intestine. And we've had a lot of calls from physicians for us to go out and give it. However, it's outside of our scope of practice. So we're actually going to go for a waiver at the state of Colorado so that our paramedics can go out and give that so patients can poop and not get readmitted for not pooping. Sorry, I never thought I'd say that in our presentation.
So we've got one more question here. Nikki Nicholas would like to know, what's the criteria that you use to establish an MOU with a home health care agency or clinic hospital?
So basically, part of it is a relationship, and then so you start there, and then if you want, I can send you what our MOU looks like. Just email me and I'll send that to you. But
it's also in the handbook.
It's also in the handbook. Oh, so we didn't have that on there. So communityparamedic.org has the handbook and the curriculum. So both of those are freely available there, as well as all of our order forms, some of our sample protocols, all of that. But specifically, the MOU has a couple pieces. One, it outlines what we expect of the provider once we're ordered and what they should expect from us. And then we also want to have training ground for our future community paramedics that are coming out of school. So it also contains an education component in there so that we can do that the home care agency, physician office, hospital would become a clinical site for us as a part of our continuing education or our initial education. And that was, again, it was vitally important to have those built in so that again, there was an understanding of what we can do, and in there it also shows all the skills we can provide, so if they ever want to refer back to it.
So really we can go to any healthcare stakeholder in our community. So we have MOUs with every primary care provider, every hospital, and multiple home care agencies that we work with. I mean, really, because it's important, we want to refer patients back and forth and work and interact with them. So the criteria for it is, are they in your community? Do they want to work alongside of you? Yes. Do they want to partner? And what's the best way to do that? But then make sure that everyone's on the same page with the document.
Great. Thank you so much, guys. Thank you for being here and sharing your expertise with everyone today. And thank you, everyone on the phone, for joining us. I hope it's been a valuable use of your time, that you've gained some information that you can use to further your own efforts to reduce readmissions and improve transitions of care. This webinar has been recorded. It will be available on the Healthy Transitions website in the next week or so. And I would just like to say thank you again and have a great day, everyone.